Good morning all. Today we are going to present our study of outcomes of gonioscopic assisted transluminal trabeculotomy in juvenile open-angle glaucoma patients. Juvenile open-angle glaucoma patients are considered to subtype of childhood glaucoma without ocular enlargement. The latest age of onset may be 40 years. Both traditional filtration procedures were reported to be effective at treating juvenile open-angle glaucoma. However, the high rate of failure and post-operative complication cannot be disregarded. MIGs like GAT are considered a conjunctival sparing procedure and are provided safer and more efficacious option. Only limited studies have been addressed efficacy of fibroproline suture GAT, and no studies have been done in Indian population on GOAG. So this was the rationale for our study. So the aim was to study the safety and efficacy of GAT in patients with GOAG. Study design, it was a retrospective study in our hospital done on GOAG patient. Inclusion criteria being the GOAG patients on maximum medical therapy or those who could not tolerate the AGMs, patient who showed progression, target IOP is not achieved even with maximal medical therapy. We excluded the case of ocular trauma, ocular surgery, corneal abnormality, and patient who were on anticoagulant medication. We divided our subjects into two groups. That was a moderate group, less than 12, and depending on mean deviation, and severe group, more than 12. So steps of surgery were blunted. All surgeries were done by a single experienced surgeon, and it was started with blunting tip of fibroproline suture. 2 mm gonadal goniotomy was done. Then the suture tip was passed to the Schlemm's canal. After 20 to 30 strokes, it was retried, and a constricted rim was formed. The outcome measures were measured in basis of intraocular pressure, AGM, and accordingly we calculated surgical success, and we denoted the complication. The success criteria we used were IOP more than 6 and less than 21 mmHg, and more than 20% IOP reduction from baseline without AGM, then it is a complete success. With AGM, it is a qualified success. This is the demographics of our study. We had 26 patients of 30 eyes, 17 male and 9 females. Age of presentation was 36.54. Unilateral cases were 22 and bilateral cases were 4. Right eye in 14 and left eye was 16. The moderate group, that is the group 1, had 11 patients, and we had 19 patients in advanced group. If we look at the IOP and anti-glaucoma medication reduction, from pre-operative to 23.43, it reduced to 14.0 at the end of 6 months, whereas the anti-glaucoma medication reduced from 2.93 to 0.80. So if we look at the same graphically, it is at every level, every follow-up visit, it was decreasing. So if we compare the two groups, that is group 1, the moderate group, and the group 2, that is the severe case, we compared the intraocular pressure and the AGM. In the both group, it was almost same. 23.73, 23.26 for the pre-op IOP, which reduced to 14.45 and 13.74 in the advanced group. Looking at the anti-glaucoma medication, there was similar trend seen. If you look at the graphical representation of the same, you can see both the lines going almost the same with not much difference. If we look at the complete and qualified success, in the group 1, we had achieved overall success of 72.7% at 6 months and a 62.5% of complete success. In group 2, that is the advanced case, we have 73.7% overall success, and at 6 months, we had 61.5%. So if we come on to complication, we had 2 patients with IOP spike. Microhyphema was, of course, a non-vision threatening complication, which was seen almost in 6 patients, which resolved within a 1 week. Macrohyphema was seen in 1 patient, in which we required intervention, but was the AC was. So if we compare to previous studies, it should be well noted that these 2-3 studies, which I have mentioned here, were uses eye catheter GAT, whereas we were using a first study, which we were using a suture GAT. If we compare the post-op IOP control, it is 15.48, and in the other studies 14.1, 15.8, 14.0. In our study, it was almost 30.9% reduction in IOP. Whereas if you look at number of AGM decline, almost it is it is 0.0, and almost ours also 0.80. So doing a SWOT analysis of our paper, the strength of the paper being no previous studies in Indian population, and the comparison was made between moderate and advanced glaucoma. Weakness be it is a short duration, of course, and we have a smaller sample size. Opportunities can be, it can be alternative to the traditional surgeries. And threat, yes, of course, we can have some patients with, which 1 patient we had with threatening complication of microhyphema, that can be considered as a threat. Conclusion be, what we already know was surgical treatment GOAG is challenging, and especially for traditional surgery has poor success, whereas GAT is effective in patient with GOAG, few studies. What our study added is, GAT is effective and safe in juvenile open-angle glaucoma in Indian population, and it is effectively both in moderate and advanced juvenile open-angle glaucoma cases, with a relative minimal complications. Thank you for the
Nice presentation. Any questions, please? Any complications did you face during GAT?
During the intraoperative procedure, sir, it was no as such complication seen. All patients received achieved a 360-degree complete GAT, sir.
You're doing under local or GA?
Not, sir, local anesthesia only.
And why do you think you compared your study with the other papers? That's a good thing. So why do you think your qualified success was much lower than the all previous papers? You saw there is 90%, but your success rate in qualified success was 50%. So is there any specific reason you can think of?
Ma'am, we had an overall success of 72%, madam, and a complete success of 62 point something. All other studies are using eye catheter GAT, madam. So, and we are started doing a fiberproline suture GAT. So might be, plus the criteria they are using are little different from ours criteria, madam. We are using an AND criteria, and we even tested for 18 mmHg and a 30% reduction. So it was also showing, but I couldn't get the last one. I couldn't.
Their qualified success criteria and yours was any different?
Yes, ma'am.
Was any different?
Yes, ma'am. We are using. We are moving a little more stringent, like they are using OR criteria. We are using AND criteria, ma'am. Like reduction, like the IP with percentage reduction also, madam.
Okay, sure. Thank
you. You have got lower volume. Do you attribute any reasons for that? What is the reason of your success?
Ma'am, sir, actually, if you look at the previous studies, even for, if you look at all MIG study and the studies which I have quoted, roughly we have 30 eyes, and of course, the sample size is less. For definite answers, we will be needing a bigger sample size. So, and of course, if you look at many studies which have been done previously, they had similar sample size. Like even the baseline study which we quoted was a KDB versus GAT, which was done by Grover et al. And they had even less, it was like case series that they had done, sir. So, yes,
my indirect question was, are you doing something different than others?
Yes, sir. We are recruiting more patients, and we are ongoing a prospective study along with that, sir, with a greater sample size.
So you have done GAT in adult patient also, adult glaucoma patient?
No, madam. These are all patients.
Not in this study,
otherwise. Yeah, yes, ma'am.
So we are doing how it is different while you are doing the prolin suture catheterization, like in juvenile cases and adult open glaucoma cases?
First of all, this is a standalone procedure which we done. In adult patient, usually we are combining with cataract surgery.
While putting the prolin suture throughout 360 degree, it is more difficult in juvenile patient or adult patient, I am asking?
It's almost the same. If you can see the trabecular meshwork and you can make the goniotomy, and if you are, it's almost if you are patient enough, that's the suture will come. Only thing is, if I think adult primary angle closure and all those cases.
No, I'm talking
open angle. It's one and the same thing, madam. Once you take out the lens or you don't take trabecular meshwork, you put the gonio lens, you can see the trabecular meshwork. The outcomes like it's easy, well easy to run, madam.